Thank you so much for having me. My name is Dan Whitney. Title of my talk is Adults with Cerebral Palsy have a high early and recurrent risk of pneumococcal disease. So people with cerebral palsy may have a greater risk of developing pneumococcal disease earlier in the lifespan than the general population. There are many childhood and surgical risk factors that can negatively impact lung function and development and increase the risk of recurrent respiratory infections. As children with CP age into their adult years, they accumulate additional risk factors that are designated as risk conditions by the CDC for pneumococcal disease. So, for example, adults with CP have an increased risk of chronic heart, chronic kidney, chronic liver, and chronic lung disease, which begins to accumulate about 1 to 3 decades earlier in the life course compared to the general population. Collectively, these factors can increase the risk of pneumococcal disease. Importantly, pneumococcal disease is considered a vaccine-preventable disease, and the vaccine is relatively cheap and generally widely available. Now, the CDC recommends pneumococcal vaccination in all children under 5 years old, and then again at 50 years of age, although that was recently changed. Not even a year ago, it used to be 65 years old. And then individuals between these two age groups with certain risk conditions like chronic heart, lung, liver, and kidney disease that are far more common in adults with CP. Now, CP and other pediatric onset disabilities are not explicitly stated as a risk condition for pneumococcal disease by the CDC. This is not surprising because the CDC makes recommendations based on the recommendations developed from the Advisory Committee on Immunization Practices, or ACIP, and this advisory committee uses evidence to guide their recommendations, oftentimes from published literature. And currently, there is no research on the pneumococcal disease burden for people, and especially adults with CP. Now, I'm eager to begin filling this gap because I suspect that waiting until 50 years of age may be too late to begin implementing this pneumococcal disease prevention strategy for adults with CP. Characterizing the epidemiology of the pneumococcal disease risk can inform on the extent of the burden and point to opportunities for policy and clinical-driven prevention strategies, such as CP-specific revisions to the pneumococcal vaccination guidelines. So the objectives of this study were to compare the time to first pneumococcal disease event and the number of recurrent pneumococcal disease events over 9 years of follow-up between adults 18 years of age and older with CP compared to elderly adults 65 years of age and older without CP. The elderly cohort without CP was included as the comparator, really to enhance policy and clinical translation. Now, the reason is that the elderly is a well-characterized clinical group for enhanced risk of pneumococcal disease and an age group where the CDC recommends routine pneumococcal vaccination for prevention. So, deriving estimates compared to elderly adults without CP may better position the evidence to determine if a greater emphasis on CP and younger age should be considered for changes in pneumococcal disease prevention-related policy. So this retrospective cohort study accessed administrative claims data from 2008 through 2019 from a random 20% Medicare fee-for-service database. To be included in the study for CP, they had to have at least 1 year of continuous enrollment between 2008 and 2010. And we used the first full year of enrollment as the baseline period. And then day 0, or the start of follow-up for the 9 years, was the first day after that 1 year baseline period. And individuals with CP had to be 18 years of age or older by day 0. The non-CP cohort had very similar enrollment criteria, except they had to be 65 years of age and older, and the original reason for Medicare entitlement had to be due to old age and survivor's insurance. Now, a group from a biopharmaceutical company led by Dr. Grant created the initial claims-based methods to detect pneumococcal disease outcomes using a 2-step algorithm. So for consistency, I followed the same methods. The pneumococcal disease outcomes were examined in the 1 year baseline period and then throughout the 9-year follow-up. I defined distinct pneumococcal disease events if the claims for each outcome was at least 90 days apart. For the primary objective, the incident rate of the first event for each outcome was estimated for the cohorts. The incident rate ratio then compared the cohorts, and Cox regression estimated the hazard ratio after adjusting for the Whitney comorbidity index, which is a CP-specific multimorbidity score that serves as a proxy of overall health and disease, and the outcome occurrence in the baseline period. For the secondary objective, the total number of pneumococcal disease events for each outcome was described and then compared between cohorts using a generalized linear model with zero inflated Poisson regression. Now, this is a two-part model that is useful for dealing with count data that has excess zeros. The first part of the model estimates the odds ratio of having a zero value versus a non-zero value. So how we interpret this is opposite of what we typically think of, because you're trying to predict, do you have no outcome event versus do you have an outcome event? So in this model, an odds ratio of less than 1 indicates the cohort with CP was less likely to have a zero value or more likely to have one or more events. The second part of the model is really what we're after, though, and this model estimates the incident rate ratio of the count of recurrent events for those that have at least one event. So here's table one, baseline descriptive characteristics. A few things I wanted to point out. We had about 24,000 adults with CP with a mean average age of 49 years old, and about 6.2 million elderly individuals without CP with a mean age of about 78 years old. Let's see if I can get my cursor on here. So despite being on average 28 years younger, the cohort with CP still had a higher comorbidity index score on average compared to non-elderly. So what we're looking at here is the graph on the left is the 9-year incidence of pneumococcal pneumonia. The incidence rate is on the y-axis, and the age group is on the x-axis, grouped in very narrow age intervals. And what we're seeing is the open circle and open triangle represent the non-elderly subgroups, and these lines just help to visualize what those incident rate estimates are. And what we could see from this visual is that the youngest age group, 18 to 25-year-old men and women with CP, have a higher incident rate of pneumococcal pneumonia compared to 65 to 74-year-olds, and it was more on par with 75-plus-year-olds, and it only got worse with older age for men and women with CP. The graph on the right is the 9-year incidence of invasive pneumococcal disease. Now, this is a very rare outcome, so men and women had to be combined in this analysis, and the age intervals are a lot wider, but a similar observation of young adults with CP have a higher incidence of invasive pneumococcal disease as compared to the elderly without CP. This graph is very similar, but what this is plotting is the adjusted hazard ratio. And the age groups here, the 18 to 74-year-old age groups for CP is being compared to the 65 to 74-year-old non-CP group. And then the 75-plus CPs being compared to 75-plus non-CP. Really, the take-home here is that even after adjusting for confounders, men and women with CP have a 2 to 3-fold higher rate of pneumococcal pneumonia over a 9-year period. And again, a similar observation was observed for the invasive pneumococcal disease outcome. For the second objective, what we're looking at here is the proportion of the total number of unique outcome events over the 9-year follow-up period. There weren't enough events for invasive pneumococcal disease, so we're only looking at pneumococcal pneumonia. So here we're looking at 0 events, 1 event, or 2 or more events. Men are on the left, women are on the right. And within these sex strata, CP is on the left, non-CP is on the right, and we can already visually see that men and women with CP have a higher recurrent risk of pneumococcal pneumonia. And then when we model this, what we're looking at here, I've highlighted in red the zero inflated model. We have an unadjusted model, then an adjusted model. Men with CP versus non-CP are on top, and women are on the bottom. And what we could see is men and women with CP were less likely to have a zero value, or, as we've shown in the incident rate figures, more likely to have pneumococcal pneumonia. But more importantly is the count model here. What we're seeing here is that of those that have at least one pneumococcal pneumonia event, men and women with CP were more likely to have a higher recurrent risk of pneumococcal pneumonia over the 9-year follow-up period. So in conclusion, adults with CP have a high early and recurrent risk of pneumococcal disease emerging about 4 to 5 decades premature. By the first stage of adulthood, men and women with CP already had a higher risk of pneumococcal disease compared to elderly without CP, and young adults with CP had a higher recurrent risk of pneumococcal pneumonia compared to elderly without CP. Thank you for your time.